Well, welcome everybody and happy end of summer and start of the school year. I think lots of people's kids are probably starting school today. Um, I was going to just chat briefly over the first like 15 minutes or so, and then um, have Dr. Jestelind, who's one of our perinatologists, talk probably starting around 12:30, and she's going to talk about advanced maternal age and management of that during pregnancy. One of the reasons I put aside just a little bit extra time is to make sure that we have the ability to talk about some changes in our ultrasound workflow. So that's what these slides will be about, and we'll get to that in a second. Um, I guess too, in terms of other things to keep in mind, I had a few requests from the OB team just to make sure that we're scheduling our or remembering to schedule our postpartum appointments for our patients. So please try to do that if you're able to get those like appointments on the books for about 6 weeks from when they'll deliver. The other thing we try to do is potentially a 2-week appointment for folks who maybe have mood concerns, um, or if you think that just for any reason that a 2-week check-in would be preferred. So please consider that too. And oftentimes if we kind of get a sense or people get a sense for that on labor and delivery that we need a sooner check-in, they will also request that. But either getting those 2 or 6 week check-in appointments on the books would be awesome. And then I guess I can open to just any other kind of like systems kind of questions or anything else that people want to bring up at this time too before I kind of dive into some of the ultrasound stuff. And feel free to put stuff in the chat as well. And if there's not, that's also okay. Okay. All right. I think also um Shelly, the lead for our OB-GYN program, is going to join while I chat about this too to see if there's any questions, and then Dr. Liz Melendez may pop on as well. So a few things to keep in mind in terms of our ultrasound workflow and some of the changes that are taking place with this. There's one of our main goals is to try to we've been having trouble with lots of ultrasounds generally being ordered and try to have the ability to accommodate patients within a appropriate amount of time for those ultrasounds. Whether it's OB ultrasounds or anything else too. And so we have a goal within the OB and family med departments to really try to utilize in clinic ultrasounds as much as possible. And I will say kind of from the start, I know that we're still working on obtaining ultrasounds for everybody. That's still very much a work in progress. And probably for a lot of people, like, working on increasing your ability or your skill set in terms of ultrasounds. And if you feel like that's not something that ultimately you feel comfortable with, that's okay too. There's still going to always be the option to refer people for formal ultrasounds. That doesn't change in any way. But for those folks who are wanting to do more ultrasounds in clinic, especially as we get the tools needed for that, then this info I think will be pretty helpful. So one of the big changes is when people call in to report a pregnancy, if they have if they do not have an LMP, so if we do not know their LMP, then the nursing team will still go ahead and order an ultrasound per protocol for them. But if they do report an LMP, even if it's not what we would call like a reliable LMP, even if it's an unreliable one, kind of per our standard guidelines for what's reliable and what's not, then we can still actually use in-clinic ultrasounds. We don't have to necessarily have that patient be referred for a formal ultrasound right away. So this is one of the big changes and things to keep in mind. And one thing to note too, and I'll link this document to our in our FMOB chat, but there's and all my slides are taken directly from this document. That really outlines this process quite clearly, I would say. So here's the general workflow, and I know it's a little bit small there too. And I see Dr. Melendez, you're on as well, and feel free to jump in too, especially if people have like clarifying questions. And I think Shelley's here too. Um, so really, this is showing that we have the nurse intake. There's either a known LMP or unknown. So unknown meaning they cannot say, with any kind of certainty when the date of their period was. If it's unknown, it's kind of the same process where an HCG is ordered, and we would want a ultrasound once it's over 10,000. If it's known, even if it's unreliable, an office dating ultrasound can be used. And then you can see kind of some of the steps that can happen after that. There may be times still where you need to still get a formal ultrasound based on what you're seeing. Going to the next slide here. I think this is what we already said too. I'll kind of go through so that people can ask questions as well. This is just the kind of the information in terms of performing the ultrasound itself. Typically, and I think most of you do ultrasounds know this, you would want to do 3 measurements of crown rump length. We can't count gestational sac measurements. And it would be the average of those 3 measurements, and then uploading a photo into the media tab or report page. And sometimes this may be one that you need to take with Haiku. But kind of making sure we have formal documentation of that information too. These would be some reasons why we would not, why you'd want to still order a formal one. One is if the gestational age is over 13 weeks and 6 days, if you're concerned about imaging quality. And I think sometimes that may happen for us a fair bit too, especially with we don't always have access to the vaginal probes. I think most of us don't. And that can make it harder to get good quality images too. If there's anything that you see on ultrasound that concerns you in terms of abnormalities, if it's a twin, or if they have a history of IUGR or SGA, those patients also should be followed by OB-GYN. And this is, again, reinforcing that if they have a reliable LMP, there's going to still be certain times where we're going to use this just tells when we would redate the pregnancy, and this is all in the guidelines as well. But I wanted to cover all that fairly briefly, and I thought this was helpful kind of information about why we want to especially use ultrasound to make sure we're dating our pregnancies accurately. I also want to just give a plug for September 3rd is the OBGYN department meeting, and 2 of our folks who are like skilled ultrasound teachers who lead the ultrasound courses are going to be speaking at that as well, and kind of giving a refresher on first trimester ultrasounds. And please let me know if you ever want to get help signing up for their course too, in terms of upping your ultrasound skills. But September 3rd would be a good date to keep in mind, Wednesday evening, in terms of getting more information. But yeah, please chime in with any questions about all of that too. That's what we're here for right now. You can either raise your hand or in the chat. Yara?
Yeah, I'm just wondering, so for us, Heather Diaz is my partner. I've worked with her outside of Kaiser. She's fellowship trained, like she's amazing. Our ultrasound machine is from the age of the dinosaurs. Like the imaging is terrible. Like we don't have a vaginal probe. So I assume we can continue to order these formal ultrasounds because that's the standard of care, is to get an early ultrasound, correct?
Yeah, totally. I think in that case, that's certainly what you have to do right now. We're looking at getting hopefully better ultrasounds and potentially the handheld models, which are a fair bit cheaper than the larger ones. But we're seeing how best to kind of go about that training and what locations to get them for. But you're right. If we don't have access to the equipment right now, you do your kind of the same approach.
You might want to reach out to our PIC, Dr. Phillips, Jason Phillips. He said we have a small ultrasound now that I guess they're going to use for ultrasound guided injections and things like that. I don't know if it has all the whatever programming that it needs to be able to perform.
Oh yeah, that's good to know.
But like Jason Phillips.
Okay, cool. Yeah, thank you.
Okay, thanks, Joey.
Oh,
We
and
also have a
Bina, you
handheld
just got the
ultrasound.
handheld one too. Okay, good.
So did I at Orchards, but I was told until they figured out what training to use to not use it.
Okay. Yeah, and Sherry is who's one of our folks who does a lot of the ultrasound classes. She's yeah, we're looking together how to get her the training and then kind of disperse it to people too. Um, but that's helpful to know. Bina, which one did you guys get at Gateway? Oh, that's okay.
Hey, this is Luis Otero. I'm with Bina. We have the V scan.
Oh, you're with Bina. Okay, got it.
Yeah.
Cool. How about questions related to that that workflow? And again, I'll send the clinical like practice guidelines over to the FMOB chat too. Maybe not as many questions as I imagined. I will, for Dr. Melendez or Shelley, would you guys like to add anything too? I know I kind of went through it fairly quickly.
Hi, can you guys hear me? I'm at another
Yep.
computer, so I'm not sure how much is going. Can you hear me?
Yeah, we can hear you
Oh,
well.
perfect. Yeah. Hi, everybody. This is Liz Melendez. I'm the chief of the department, and I just put in the chat that for this department meeting, it's going to be in person, and it's scheduled to be in the Oregon conference room. This particular portion of the meeting will be at 6:30, and we're hoping to give our sonographer about 45 minutes to go over a pretty robust just PowerPoint showing some imaging. The idea really is to avoid duplicate work. So if you're already doing the ultrasound, not having a repeat ultrasound, if you're able to get an ultrasound done, not ordering that extra ultrasound. But if you're in a location where there is either, you don't have the equipment or you don't have the right equipment, then don't stress about this. We will work on the back end trying to find that equipment. Ultimately, it'll be our health plan partners' decisions, whether they invest in that for the sake of reducing the need for first trimester ultrasound. But I don't want you all to stress about it too much. We would appreciate whatever you can to help us in this work, but we definitely recognize that you're not in this space too often and you don't necessarily even have the right equipment. So thank you, Tovi, for trying to initiate this work wherever it is possible to implement it.
Yeah,
Hey,
yeah.
Tom,
Thanks, Liz.
this is John. I got a question. Do you have any take on transabdominal versus transvaginal and first trimester ultrasounds? And also in the context of the trophon, which is sometimes tough to maintain.
Hi, Jonathan. I didn't hear what part is tough to maintain.
Some of the vaginal probe, I believe the trophon part of the vaginal probe.
Oh, you mean like the cleaning part and all of that, the
Yeah.
maintenance of it. Yeah. So I think, predominantly are doing transvaginal for first trimester ultrasound. And so I think that would be the preference. Uh, for most of our patients, unless you've got a super thin patient and you can see a nice crown rump length with that abdominal ultrasound. I don't think you have to have a transvaginal one if you're able to get a good image abdominally.
Yeah, I think that's a tough thing for a lot of our clinics too, like because of cost, we haven't been able to keep our transvaginal probe. And so I I think transabdominal is acceptable if you can get the good enough images, but I think that does make it, it's a lot harder when you don't have access to the vaginal probe.
Right.
And that would be an issue with the smaller ultrasounds too.
Sure.
Yeah.
And again, this project is not intended to remove the option of ordering that radiologist's formal ultrasound from your toolkit. It's really just meant to reduce any duplicate work. So if you already see an opportunity to scan somebody yourself and can confirm that LNP, then she doesn't need a radiology ultrasound. But if you cannot do that confirmation ultrasound, then you still order the ultrasound as usual.
Yeah. Yeah, and hopefully we can use this project too to just continue to show that it's important for us to be able to have the ultrasound skill set, especially for those who want to keep it up and yeah, and continue to keep this as like part of our scope of practice.
Yeah, and certainly it's not meant for this project, but being able to confirm whether someone's breach or vertex would be a really big gain for those buildings that don't currently have an ultrasound. So that's sort of an additional bonus there.
Yeah. Thanks, folks. I think we should transition over then to Dr. Jestelin's talk. Since we have just under half an hour. So thanks again to Dr. Melendez and Shelley for joining too. So I think then, Chad, we could maybe switch back over to the other slides if that's okay. Or I could, if you need me to stop sharing too, I could do that. Here, I'll stop sharing.
Okay. Am I the one that had the slides, or does someone else have the slides? Want me to just put the ones I had before?
Sure, yeah, if you want to put up the ones you had before.
Take me a second. Sometimes it takes a while to load.
Oh, no problem. Maybe I'll do my little intro of Dr. Jestelin right now then while we're getting the slides to load. So we're really happy to have her joining us today. Just some info about her. She grew up in Salt Lake City, Utah, went to Whitman College, which is my college too. During junior year, spent a semester in Kenya. She says, my time in Kenya ignited a deep interest in public health and more specifically maternal and fetal health. Went on to study public health at the University of North Carolina, Chapel Hill, and after that opted to go to medical school. She did her medical school and residency training at the University of Utah and came to OHSU for maternal fetal medicine fellowship and has been at Kaiser for about 8 years in total. Went back to Salt Lake City to be near her folks when her kids were younger and worked in a private MFM practice there for 7 years. So thank you again for joining us.
Yeah, no problem. Thanks for having me.
Yeah.
Do you need me to locate slides or? Oh, no, looks like you got it. Great.
It just takes a little bit of time. And then if you take control, you'll be able to move the slides and everything.
Oh, excellent. Great. Well, thank you. Yeah, thanks, Toby, for letting me pop in. I realized I had 31 slides, so I'm going to probably go through pretty quickly, and I may not cover absolutely everything on every slide just to kind of get to the meat of the important stuff. But Toby asked me to talk about advanced maternal age today, and as you guys are all aware, the definition of advanced maternal age is that of being 35 or older on their estimated due date. So that's important to remember. It's not necessarily what their age is when they come in for their first prenatal visit, but if they're 35 or older on the day of their estimated due date, they're technically advanced maternal age. The definition it emerged way back in the 1980s, and that was at a time point when they started to see evidence of declining fertility, increased risks of genetic abnormalities, and sorry, I'm going to advance forward. Sorry, I forgot I had control. What's the? Sorry, I just click on it, right? I'm so sorry. I'm going to go back here real quick to say I don't have any disclosures of note. I bypassed that entirely. I apologize. I don't know if you guys want this now or later. I know in our meetings it comes at the very end, but I'm happy to circle back around to it. So sorry, I raced forward, which I apologize for. But these are the primary objectives today, which is really to provide the definition, review the epidemiology and shifting trends, specifically review the maternal and fetal risks of advanced maternal age, as well as the potential benefits, and then to kind of review through current recommendations for management in these pregnancies. So getting back to definitions, again, classically defined as 35 or older, though more recent studies have started to use the definition of a very advanced maternal age, 45 or older, or even greater than or equal to 50. And that's because many of the risks with pregnancy do not become evident until these much more advanced maternal age. But in truth, really, as we all know, you know, the risk of advancing maternal age is more of a continuum rather than a dichotomy. You know, with age, we all accumulate medical issues, and really with those medical issues, that's where the increased risk comes with pregnancy. So this is just more out of fascination than anything else, but actually both of these occurred in 2019. But the oldest known women to give birth, one naturally was in China. She got pregnant at age 67. She apparently had had a minor stroke and started taking all sorts of herbal supplements. And her menses unexpectedly returned, and she found herself pregnant about a year later, and then subsequently had a healthy, uncomplicated full-term delivery by C-section. And then by IVF in India, this one made news as well, obviously, but this woman and her husband, who was 82 at the time, had been trying to conceive throughout their entire lifetime. Ultimately, someone was willing to do IVF for her using donor eggs, and she gave birth to twin girls. Her husband died a year later from a heart attack. So that was an unfortunate part of that story. So there has really been a steady rise in pregnancies in both those 35 or older and 40 or older. Recent data from the CDC, this graph shows data from the CDC between 1972 to 2002. And you can see that for age 40 or older, which is the purple line here on the bottom, you can see that there's been a gradual steady incline, even more notably for the 35 to 39-year-olds. In contrast, which is really good news, the risk for 15 to 19-year-olds has gone down dramatically, and 15 to 17-year-olds, you can see even more dramatically. So actually, for the first time in history that, or known recorded history, the rate of births in women 40 or older versus those less than 15 kind of overlap. So in 2022, 19% of all births were in women 35 or older, and 4.1% of all births were in women that were 40 years or older. So there are multiple reasons why parenthood is being delayed. Obviously, there's increased availability of reliable contraception, increased availability of advanced reproductive technologies, and more insurance companies that are offering some coverage for these services. People have been afforded wider opportunities with regards to education and career opportunities, which often leads to a delay in starting a family. People are getting married later. There are many more second marriages. And interestingly, for older patients, they have a much higher prevalence of contraceptive non-use, often because they think they can't get pregnant, and then oops, there they are pregnant again. And actually, I just saw a patient literally 2 hours ago who's 45 years old, and she had done, I don't know, probably 10 rounds of IVF that were all failed, and then spontaneously pregnant at 45. Like they just had given up and decided things were not going to happen, and now she's pregnant at 45. So I'm trying to figure out how to advance here. Sorry, I'm not very Teams adept. So risks of AMA, I'm going to kind of breeze through these pretty quickly. Early in pregnancy, the risks, as we know, for miscarriage go up fairly dramatically, not only for aneuploid fetuses, but also euploid fetuses. Aneuploidy, is thought to occur largely because of the decline in oocyte quality that comes with age, but also from changes in the uterine and hormonal function that can occur. Most of these losses occur at 6 to 14 weeks. And then advanced maternal age patients are also at increased risk for ectopic pregnancy, as high as a 4 to 8-fold increased risk. Age also increases the morbidity and mortality for ectopic pregnancies as well. We know that advanced maternal age patients that get ectopic pregnancies often have worse outcomes. This table shows the percentage of miscarriages based on age, and you can see that risk goes from 11 to 13% at the younger age groups to as high as 93% for those 45 or older. And then likewise for ectopic pregnancies, you can see the risk kind of goes up for that 1 to 2%, up to 7% for the higher age groups. There's also an increased risk of aneuploidy, as I just touched on briefly, but the most common aneuploidy that we tend to see with advanced maternal age is autosomal trisomy. The figure on the left shows the risk of the most common genetic conditions by maternal age, and you can see that for all of the trisomies, the risk goes up steadily from 35 onward. And again, this is felt to be due to errors in non-disjunction. As we all recall, women are born with all the eggs that they'll ever have. The eggs pause in metaphase and remain aligned on the metaphase plate until just prior to ovulation, which means they are much more prone to error with age and, are also exposed to potentially, dangerous environmental exposures over time. You can see on this graph, interestingly, that the risk of triploidy and sex chromosome abnormalities does not go up. Some studies suggest a very slight increased risk, but overall they remain fairly unchanged. The table on the table on the right shows the numerical risks. This is from the New England Journal, and you can see risk of Down syndrome here in the middle. The risk goes from 1 in 1,600 to 1 in 30 at age 45. And then if you look at any chromosomal abnormality, you also see that risk goes up pretty dramatically from 1 in 526 to 1 in 21. There's minimal data really with regards to risk of things like single gene disorders. Some studies suggest that there may be an increased risk of autism spectrum disorders with advanced maternal age and paternal age, but the studies are not conclusive, and age alone has not yet been proven to be an independent risk factor for autism, which means that there are likely confounders, medical and environmental issues that may be contributing to this risk. People who are AMA are also at increased risk of congenital malformations. I won't go into the details of this slide just for the sake of time, but most studies, if you look across multiple studies, generally you see a slight trend towards an increased risk of congenital malformations. And this is despite this is unrelated to chromosomal conditions, meaning isolated cardiac defects, isolated esophageal atresia, anomalies that are unrelated to a genetic disorder. And those risks can range anywhere from a 1.6-fold increased risk to a 2-fold increased risk. The FASTER study, which many of you may remember from years ago, they found that the rate of major anomalies by age kind of went up steadily with age. So less than 35, the risk was 1.7% to up to 3% for those 40 or older. Oops, I'm sorry. The other risk with advanced maternal age is multiple gestation. These are actually my twins that I had at age 39. They're now almost 17, but with advanced maternal age, there is an increased risk not only of twins due to advanced reproductive technologies, but also spontaneous twins. And the risk of spontaneous twins is thought to be due to hormonal changes as women age. So there can actually be a rise in FSH that leads to the release of multiple eggs during ovulation, which puts women of advanced maternal age at increased risk. This figure on the left shows the age in years and the number of twin pregnancies per 1,000 live births. And you can see for all ages, the risk was 30.7, and this is data from 2024 4. This is recently published. And that rate is as high as 78 per thousand for the 45 to 54-year-old age group. Oops, going to go back there. So interestingly, yeah, in 2024, 23% of all twins occurred in women 35 or older. With age often come additional medical issues. That's really the biggest concern. Increasing age, we all tend to accumulate medical issues, cancers, cardiovascular disease, hypertension in particular, renal diseases, autoimmune diseases, specifically diabetes being a big one, and obesity rates are much higher with age. Some studies that have been published have estimated that the coexisting medical conditions lead to a 2 to 3-fold higher rate of complications in pregnancy, including hospitalizations, C-sections, and other pregnancy-related issues. I'll get into this in just a minute. Hypertension is by far the most common chronic medical condition we see with advanced maternal age, occurring at a rate of 2 to 4 times higher than their younger counterparts. Advanced maternal age is also associated with an increased risk of preeclampsia, with the general population risk being 3 to 4%. That risk goes up to 5 to 10% for those 40 or older, and 35% or higher in those 50 or older. In turn, with hypertension disorders, there's increased risk of other complications like fetal growth restriction, preterm delivery, and C-section risks. Advanced maternal age is also associated with an increased risk of C-section. This is data that was published also this is from 2021 to 2023, published in 2024. The overall C-section rate was 32%. And you can see it kind of just steadily went up with age, with rates as high as 48% for those who are 40 or older. The higher risk of C-section is thought to be due to multiple factors. They have a higher rate of uterine dysfunction, leading to labor protraction and arrest disorders. Medical comorbidities certainly increase the risk of C-section. And also there's definitely a lower threshold for C-section, not only by patients, but providers of folks that are 35 or older at the time of delivery. So there's, again, with age, it tends to get worse the older you get. And so more and more studies are coming out looking at specifically very advanced maternal age versus just advanced maternal age. One large study that was published out of Los Angeles looked at groups, the 35 to 44-year-old group compared to the 45 or older group. And in the greater than 45-year-old group, they found higher rates of C-section, postpartum hemorrhage, chronic hypertension, preeclampsia without severe features, preeclampsia with severe features, and NICU admission. So, the older a patient is, the higher the risk of almost every complication you can think of. There's also notable increased risk of, I skipped one here. So there's also increased risk of severe maternal morbidity. When we think about severe maternal morbidity, we're talking about things like pulmonary embolus, amniotic fluid embolism, ICU admission, hysterectomy. And, several studies have shown that women of advanced maternal age, particularly 45 or older, are at a marked increased risk for severe maternal morbidity. I'm not going to go through all the numbers here for the sake of time, but you can see, at least from this top study in 37 million deliveries, that 45 or older women had 3.5-fold increased risk of severe maternal morbidity. There's also an increased risk of mortality. While the absolute risk remains low, there's still a substantial risk, as this figure shows. This is data from 2018 to 2022. All age groups, saw a steady increase in mortality between 2019 and 2021, which was felt to be related to the COVID pandemic. But you can also see that for just within each age group, so the advanced maternal age group being this bright orangey color, that their risk is markedly higher throughout every year. And in looking at shared numbers, overall, their rate is 6 to 8-fold higher than those 25 or younger. There's also an increased risk of preterm birth. Overall preterm birth risk in the United States in 2023 was 10.4%. This is data from March of Dimes from 2021 to 2023. And women 40 or older had the highest rate of preterm delivery at nearly 15%. The likely reasons include, again, medical comorbidities. Advanced maternal age is also associated with increased risk of placental complications like placenta previa, placental abruption, uteroplacental insufficiency, and again, multiple gestation certainly plays into the risk of preterm delivery as well. Sorry, I know it goes on and on in terms of increased risk, but we'll also get to some good things too. So there is an increased risk of low birth weight and fetal growth restriction. Again, there's a lot of data on this particular slide, and actually I'm just going to point you down to the very last bullet point. But there have been several studies, case control, large cohorts, population registry studies, and all have demonstrated an increased risk for fetal growth restriction in women over 35. The odds ratio for 35 to 40-year-olds ranged from 1.2 to 1.6-fold increased risk, and for 40 or older, that risk is 1.4 to 3.9-fold higher. There's also an increased risk of stillbirth or IUF, intrauterine fetal demise by maternal age. Remember, stillbirth is defined as any loss of a fetus at 20 weeks or later. The overall risk in the United States in 2023 was 5.5 per thousand. This risk was highest at the extremes of age. So if you look at this is data from the National Vital Statistics report published in 2025 in June, and you can see it kind of has a U-shaped curve with the highest rates occurring in those younger than 15 and those 45 or older. Looking at risk of stillbirth by gestational age. And this is helpful just because when we start thinking about management of these pregnancies, this is sort of the data we use to kind of make some of the decisions that we do. A large observational study looking at greater than 7 million pregnancies looked at the rate of stillbirth per 10,000 by gestational age, broken down by maternal age. So these are all color-coded down here on the bottom. And you can see this is the 45 or older group, this big, dark, steep line that kind of starts to shoot up. If you look at all groups, you can see that the risk of stillbirth starts to creep up right around 39 to 40 weeks, kind of gradually. But for age group 40 or older, and even more so for 45 or older, that risk really dramatically starts going up at 39 weeks. So it really starts going up earlier for those particular age groups. Risk for stillbirth, again, the reasons that there may be an increased risk of stillbirth, it kind of circles back to all those same things. So comorbidities, diabetes, hypertension, placental factors, additional OB complications, likely uterine and hormonal factors, all those things are likely players in that risk. Though even if you exclude or confound or control for potential confounders, their risk is still increased compared to the lower age groups. So there are some benefits to advanced maternal age, although there's really very minimal data. It's not really been well studied. Many think that there may be improved emotional readiness, improved financial stability, stronger support networks, improved access to healthcare. But again, no studies that have kind of come out and specifically identified or quantified those benefits. There is one study that was published back a while ago, back in 2012, actually from the UK, and that did show improved health and development outcomes for children from age 9 months to 5 years. They had lower frequency of unintentional injuries and hospital admissions, lower frequency of of other hospital admissions due to other causes, and they had higher immunization rates at 9 months of age. In addition, the study showed some improvement in language and social development as well. So kind of getting to really kind of the meat of how we think about these pregnancies and how we make recommendations for following them and managing them. These are recommendations that are taken directly from ACOG's OB Care Consensus that was published in 2022. This is a quote directly from that consensus, and it says, "We suggest that pregnancy with anticipated delivery at 35 years or older be recognized as a risk factor for adverse maternal, fetal, and neonatal outcomes when counseling patients and determining management plans. Nuanced counseling will be dependent on pregnancy individuals' specific age and comorbidities." So this is a fairly generalized statement, but it does highlight the importance of recognizing this patient population as being at risk and keeping this in mind when kind of mapping out a plan of care for them. So early in pregnancy, really first prenatal visit, we recommend an ultrasound for viability and dating, which we just touched on. This is even more important, I would say. Well, it's important for any pregnancy, but even more important for patients who are advanced maternal age or older, particularly given their higher risks of multiples and growth restriction. We've actually had, I think we've seen 3 sets of twins in our clinic in the last month that were not identified actually until their 20-week anatomy scan. And these were all folks that did have scans in the office. So I would propose that obviously if there's any concerns with imaging ability in the office, particularly in this higher risk patient population, that they should have a formal scan for viability. Genetic screening and diagnostic testing should be reviewed and offered. I know everyone's, clinic time is limited, and I know it's really hard to go through all these options. So if you have a patient that is interested or expresses interest in invasive testing or has lots of questions about genetic risks, then I would refer them to genetics. But screening options should be reviewed, including NIPT and AFP testing. Diagnostic testing technically should be offered and discussed to any and all patients, including chorionic villus sampling and amniocentesis. And then more recently, we've started offering, and ACOG has been recommending, which I'll get to again in a second, a first trimester detailed anatomy scan in perinatology. We typically do these between 11 and 13 and a half weeks. It can only be done in perinatology. It's kind of the classic, nuchal translucency ultrasound, although we are not calling it that as much anymore because really it's more about first trimester anatomy. A publication that actually literally just came out. It says September 2025, which it's not even September, but this came from ACOG clinic practice update. And they recommend that individuals with known risk factors for anomalies have access to a detailed first trimester fetal anatomy scan. And they suggest 12 weeks, 0 days to 13 weeks, 6 days, which is a great window of time actually, because we can actually see a lot of anatomy.
Quick question for you regarding that.
Yeah.
I guess, do you think that we should be pretty strongly recommending most of our patients, even if they're kind of on the younger side, like, they're 34, but going to deliver at age 35 for this kind of imaging? Like, can you guys support that as well?
Yeah, that's a good question, Toby. I mean, the tricky part is access is the other part of them, that it could potentially be hard for us to see every single one of those patients. I guess what I would say is it should be offered. I would say 40 or older probably encouraged, but also still optional, right? I mean, I'd say if you have a patient though that comes in that's 35, 36, and they have a lot of questions about genetic screening or testing and have a lot of worries or concerns specifically, and you get the sense that they would strongly consider termination for anything, then I would definitely send them our way. One thing to just remember is that if they come in and they're already 12 weeks, we probably can't get them in. We might be able to, but but there's no guarantee that we could get them in that time frame. But in theory, in an ideal world, all these patients are being offered, first trimester detailed scan. That's it's a tricky one though, but because I'm not sure if we can honestly accommodate all of them at this point. We've been doing a lot though, and it helps give us the ability to push for more space, and I see that Liz Melendez is still on here, so I always bring up space just so she hears it. But anyway, so I guess the answer to that, long-winded answer to that, Tovi, is that yes, it should be offered. I'd say, well, I'll get to the next slide too, because it shows, there's a lot of advantages to a first trimester scan. This table does show kind of the folks that should be offered first trimester scan. And we do, if you go into perinatology referral, for those of you that have done it, you'll see an option for ordering an NT ultrasound, which is essentially this. We just have kind of kept it that same name. And you can order it outright, and then we'll get them scheduled. It lists these indications on there as well. And, if you have any questions, we have patients that are not AMA that opt to have an NT ultrasound. They had it in a prior practice or a prior pregnancy, and they just think that that's what they're supposed to have. But where did that? Oh, actually, sorry. I'm going to try to look at my. Yeah, so detection rates for the first trimester scan. So our machines, first of all, our machines are getting better and better, and we really are able to see more and more than we used to be able to, and can rule out a lot of potentially very scary things early in pregnancy. Big things we're definitely not going to miss are things like anencephaly, abdominal wall abnormalities, a severe cardiac defect, a severe neural tube abnormality. Most reports suggest that cardiac defects can be detected at least 30% of the time with an early scan. That's why in folks who have a strong family history of cardiac defects, we recommend the early scan. So, a lot of potential benefits. The other piece of that is that, if people want all the screening and testing under the sun, because it may influence their decision-making with pregnancy, then really this offers a lot more than just the NIPT. An NIPT, it literally only captures 4 things, Down syndrome, trisomy 18-13 risk, and sex chromosome abnormalities. But we have plenty of people that have totally normal NIPTs that come in and their baby has a whole host of anomalies that are unrelated to any of those conditions. So, people can make decisions earlier. And, I think we're lucky. We live in Oregon, so people have a lot more flexibility with their decision making in terms of pregnancy. But there's going to be a bigger push for this kind of nationwide, just given all the restrictions on abortion care. So we want to kind of stay ahead of the curve in terms of trying to keep on top of, detecting these things as early as we possibly can. So along the line of things we should be talking about with patients, daily low-dose aspirin. We recommend starting at 12 to 16 weeks for advanced maternal age patients that have at least one other risk factor, whether it be a high risk factor or a moderate risk factor for preeclampsia. So again, daily low-dose aspirin has been shown to reduce risk of preeclampsia by about 25%. So this should be offered and discussed with patients. The OB checklist has these factors listed in there. And so if you go in there and kind of click on the aspirin, it will list those other risk factors. And I would say the vast majority will have one other risk factor. Second trimester, moving into second trimester, a detailed anatomy survey obviously should be offered to everyone. Of note, the ultrasound that we do in perinatology is different than what is done in radiology. They do something called a 76805, which is a basic anatomy scan. And in perinatology, we do something called the 76811, which is a detailed anatomy scan, which does include multiple additional views of brain, heart, facial structures. So it is a much more detailed scan than they're going to get in radiology. So if you have patients that have, significant risks for structural abnormalities, or again, a 40 or older patient in particular, I would recommend sending them our way. They don't have to if they live far away. People don't have to choose to come see us, but we are happy to scan any and all of those patients if we're able to get them in. In addition, when we see them, as you likely know, we do meet with them. So if there's a worry or concern, they know same day. We're talking to them. If they want invasive testing, we can do it that same day. And patients typically really like that. Third trimester, so given the increased risk of stillbirth, particularly for those 40 or older, a few things. We recommend some additional monitoring towards the end of pregnancy, as well as kind of a change in delivery timing. For 35 to 39-year-olds, we still recommend, our group recommends a fetal growth ultrasound in the third trimester. ACOG says it should be done in 40 or older. So 40 or older, absolutely, they should get a growth scan. 35 to 39 years old, I'd say it's optional. Our group, just of note, when we see patients, we tend to order a third trimester scan on all those patients. There are things you're going to see in the third trimester that you're not going to see in the second trimester. So if we can find any good reason to do a third trimester scan on a patient, we will recommend it. That can be done in radiology. That doesn't have to be done in perinatology. But we recommend a third trimester ultrasound for growth. And then for 35 to 39-year-olds, recommend offering induction of labor between 40 and 6. Now, they don't have to choose to do that. But given that the increased risk of stillbirth starts to kind of creep up, towards the latter part of 48 weeks, we typically recommend at least offering them that option. And then for 40 or older, we recommend some sort of fetal monitoring. There's no data to really support what that monitoring should look like. ACOG very vaguely says, additional monitoring should be done. So our group, decided that it seemed reasonable to start weekly non-stress tests at 36 weeks and offer induction at 39 to 39 and 6, just based on, again, on that increased risk of stillbirth. So sorry, I know this is kind of, I'm trying to go through fast, but take-home points, advanced maternal age is associated with a number of increased risk of pregnancy complications. Risks are highest for those 45 or older. Pregnancy care really should be tailored to maternal age and comorbidities, and not just, a 35-year-old who's totally healthy. Likely they're going to do very well in pregnancy, but they should get a little bit of additional attention and monitoring. And pregnancy care should include a discussion of all these risks. Sorry, I've got a couple more slides. Actually, just one more. Yeah, and I won't go through all this because it just summarizes the last few slides. But again, the daily low-dose aspirin, the genetic and screening and testing options, when and what kind of ultrasound should be ordered. I did put in here TOVI, especially if 40 or older. A third trimester ultrasound for growth, and the antenatal testing. We do have that in our guidelines. Our guidelines say exactly what I just put on the last slide two slides ago. And these were the primary references from today, although there were multiple others that were kind of listed within the slides themselves. But both of these are very useful resources for kind of these pregnancies, and especially this obstetric care consensus that ACOG published fairly recently. So I know that was a lot and I ended a little late for you guys, but questions I can answer.
Okay. Yeah. No, thank you so much. That was super helpful. Yeah, some people had to pop off, but we record this and other people will watch this separately as well. So we really appreciate your time.
Oh, no problem. And again, we're happy to see any and all these patients if we can get them in, but no guarantee if they're already a little ways along, but we can usually get them in for sure for anatomy.
Yeah, sounds good.
All right.
Well, thank you so much, everybody.
Thanks, you guys. Sorry for keeping you over. Yep.
No worries. Bye-bye.